Hello, everyone, and welcome back to another webinar, Tuesday webinar on HEMONC. So today's presentation is going to be on Neutropenic Fever, and with us we have Dr. Abuali. So we're really excited to have her here to give this talk. She specializes in hospital-based hematology and oncology at Massachusetts General Hospital with Harvard Med. She recently completed her fellowship at the University of Cincinnati College of Medicine, and she's also a columnist for ASCO and aspiring novelist who has a passion for social justice and gender equality. We are really excited to have her here today. And as you know, we have listeners who benefit from these talks all over the world. So we're really excited to have her give the talk today. If you have any questions during the presentation, feel free to put them into the Q&A or the chat box, and then we'll get to them at the end of the presentation. So you can just type them in there, and then I'll help moderate and get those questions answered at the end. So with that, don't want to take up too much time. Dr. Abuali, it's all yours. You should be able to screen share.
Thank you so much. Thank you. All right, can everyone see my screen? Perfect. All right, so good morning or good evening, depending on where you are. It's my pleasure to be here today talking to you about neutropenic fever. So I have no disclosures, but I am an adult oncologist, so my lecture is just limited to management of adults with neutropenic fever. There are some different nuances for the pediatric population, which I will not be covering today. So my objectives today is to help us define what neutropenic fever is, help us risk stratify patients with neutropenic fever, learn how to evaluate and treat those patients, and then discuss the role of colony stimulating factors, both in management of febrile neutropenia and in primary and secondary prophylaxis. And then throughout this talk, I'll sort of be using the terms interchangeably, neutropenic fever or febrile neutropenia. You'll hear people just refer to the same thing differently. All right, so we're going to have some clinical scenarios to help us set the stage and work through the presentation. So this is the first clinical scenario that we have. You have a 65-year-old male with metastatic prostate cancer that you're treating with docetaxel. This is just one of our chemotherapeutic agents. He presents to your clinic for an urgent visit. So 7 days ago, you gave him his first cycle of chemotherapy, and then he calls you up and says he needs to come in for an urgent visit, that he's feeling tired and is not feeling well. You check his vital signs in clinic. You notice that his temperature is 39.5 degrees Celsius. Heart rate is 110, so a little tachycardic. Blood pressure is 120/70, and his pulse ox is 98% on room air. He's basically just complaining of fatigue, but there are no other focal symptoms that you can elicit. So what would you do next for this patient? So first, let's review some basics. We talk a lot about febrile neutropenia. Well, what exactly is neutropenia, and what exactly is an absolute neutrophil count? So the thing that you're looking for here is an ANC. So ANC is basically the white blood cells in your body that are fighting the infection. So you calculate it by multiplying the white blood cell count by the percent of the bands and polymorphonuclear leukocytes. Those are the specific white cells that fight the infection. And this is what we mean by when we say ANC, absolute neutrophil count. The second piece of this is the neutropenia. What exactly defines neutropenia? So there are different definitions put forth by societies. Here in the US, we use the IDSA definition. That's the Infectious Disease Society for America. And it basically defines an ANC of less than 500 as neutropenia, or an ANC of less than 1,000 with an anticipated decline to less than 500 in 48 hours. So for example, one of your patients with cancer that you're anticipating an ongoing decline in counts because you have just given them chemotherapy. So either ANC of less than 500 or an ANC of less than 1,000 and anticipated to go further down. And then when you read certain papers in the literature, you will hear some other definitions where sometimes the neutropenia is risk stratified, less than 1,000 being moderate neutropenia, and less than 500 being severe neutropenia. So that's something else to bear in mind, even though it doesn't really, honestly, in clinical practice, it doesn't really make much of a difference. We pretty much manage them the same. When I was back in med school, several years ago, less than 1,500 was a definition we used to use. Nowadays, there is a growing awareness that there is variability in ANC counts among different ethnicities. So for patients more of African descent or Middle Eastern descent, it is noted that their white counts might be a little lower at baseline and their ANCs might be a little lower at baseline without really an impact on their clinical course. So we don't really use 1,500 anymore as a definition for neutropenia. So it's less than 500 or less than 1,000 and anticipated to continue going down. So putting those together, when we talk about febrile neutropenia or neutropenic fever, you have to have the fever. So the fever part of it is a single oral temperature of 38.3 degrees Celsius or more, or as we use here in the US, 101, or a temperature, a sustained temperature of 38 degrees or more, or 100.4 or more over a 1 hour period. So you have to meet your definition for a fever and then your definition of an ANC less than 500 to have a neutropenic fever. And this is an oncological emergency. While those patients may look okay because they're immunosuppressed and are not really able to mount much of a reaction to the infection, this is an oncological emergency that has a high morbidity and mortality if not managed appropriately. So going back to our patient, the gentleman with prostate cancer that you just gave chemotherapy to and now has a fever and is presenting in your clinic, you check a stat CBC in your clinic and you notice that he has unexpected chemotherapy-induced pancytopenia. So he has a hemoglobin of 9, white blood cell count of 800, 200 of those are his ANC, his absolute neutrophil count, and his platelets are 88. So you know that this patient meets the definition for febrile neutropenia. Well, how do you risk stratify it? Are all neutropenic fevers the same? So we came up with 2 risk stratification scores to help us evaluate how sick our patients are and how to most appropriately manage them. The first risk stratification tool is the MASC, the Multinational Association for Supportive Care in Cancer Risk Index. It's a long name, it's just the MASC Risk Index. And this has several characteristics that are weighted differently. The higher the score, the lower the risk. So if your patient does not have many symptoms, he gets 5 points. If he's hemodynamically stable, doesn't have hypotension, that's 5 points. If he doesn't have any additional comorbidities that confer an increased risk, he gets points for that. If he has a solid tumor and no prior infections, that is also something favorable because we know that patients with with hematological malignancies have a higher risk and a prolonged risk for neutropenias. If the patient is not dehydrated, if the patient is in the outpatient status and younger, all of those are favorable. So risk score of 21 or higher denotes a lower risk. And when we say low risk, it means that when we validated this in clinical studies, we saw that this means 90% of uncomplicated fever resolution occurs within 5 days. So that's one risk stratification index that you can use. And you never really have to memorize any of those stratification scores. You can always look them up online, plug in the information and get it calculated. The other one that is a little bit more popular, mainly because it has less variables and is quicker to use, is the Clinical Index of Stable Febrile Neutropenia. This one is the opposite. This one, the lower your score, the better your prognosis risk. So this looks at performance status. So we use performance status a lot in oncology to risk stratify patients, the ECOG performance status. Basically, you and I have a performance status of 0 if we're healthy and fully functional. And then 1 is when you start having some symptoms, you're not at your usual baseline. 2 is when you're not able to do your normal activities. 3 is when you're spending more and more time in bed. And 4 is when you're mostly bedridden. So when patients are starting to have symptoms and not able to do their usual activities, they get 2 points for this. If they have stress-induced hyperglycemia, that's another 2 points. If they have some comorbidities like COPD or cardiovascular disease, they get points for that. Mucositis is another point because having mucosal membrane injuries predisposes to bacteria entering the bloodstream, and then having lower monocyte counts. So this specific risk stratification score breaks you down into 3 classes, either low when it's 0 points, or intermediate or high risk for 3 points or more. And when we validated these scores in clinical trials, this one is more accurate than the MASC score. It is more specific for identification of lower risk patients and is the tool that we most commonly use in the ER. In general, though, with those risk stratification scores, you never want to use them on someone who's just frankly very ill. So if a patient is presenting with septic shock, you really don't need to even use a risk stratification scores. You know that those patients are very ill and need to be hospitalized. So let's go to our patient. The gentleman with the prostate cancer. He said he doesn't have many symptoms. His blood pressure was fine. When you ask him for his past medical history, he doesn't have any COPD. He has a solid malignancy. He didn't look dehydrated on exam, and he was outpatient because he came to you in clinic. He was 65 years of age, so he doesn't get this point. So when you calculate his risk score, you identify it to be 24. So this is a low risk patient. Now, what are we going to do with this information? So what I'm trying to get at is that in very select cases, those patients can actually be managed in the outpatient setting. And I think this becomes important, especially in the era of COVID, where a lot of our patients don't want to be hospitalized and want to minimize the risk of COVID exposure. Some of our patients we can actually monitor and manage in the outpatient setting with some very important caveats. It has to be a low risk patient. You have to have the ability to monitor them very closely. They have to have a phone. They have to be able to reach the hospital and live close by to the hospital. And be able to admit them if the fevers persist for 48 hours or more. The antibiotic choice that we use here, and we're going to talk more about antibiotic coverage in later slides, is basically we're trying to cover them broadly. So we're going to use ciprofloxacin in combination with augmentin, for example. And this way you're covering this broad array of gram-positive and gram-negative organisms. If patients are penicillin allergic, because that comes off often, then you can substitute the augmentin with clindamycin. So in very select cases, you can manage some of your patients with neutropenic fever in the outpatient setting with very close monitoring and admitting them if necessary. Now let's look at another patient, another clinical scenario, which is really the more common scenarios that we face. So we have here a 72-year-old woman. She has triple negative breast cancer, and she is 6 days post her first cycle of chemotherapy. You're giving her dose-dense AC. She presents to the ED with a fever of 40 degrees Celsius, and she's complaining of abdominal pain, chills, and myalgias. She was unable to do her usual activities this past week. You calculate her performance status to be 2. When you check her vital signs are not stable. So she's tachycardic, heart rate is 120. She's hypotensive, blood pressure 90/60. And her pulse ox is 92% on 2 liters nasal cannula. She also has several underlying comorbidities. So she has COPD, she's not on home oxygen. She has coronary artery disease, and she had some cardiac stents placed a few years ago. And she also has type 2 diabetes. Notable labs are an ANC of 50, so she's definitely neutropenic, and her blood glucose level is 250, so she has some hyperglycemia there as well. So this patient presenting to the ER is a different scenario, and when you try to risk stratify her, she gets points for performance status of 2, points for stress-induced hyperglycemia, for COPD, and for chronic cardiovascular disease, and you stratify her as high risk with a risk score of 6. So this is a different scenario, and those patients are much sicker and need to be hospitalized. So there are certain important things that need to be done in the ER. Those patients, when a patient presents to the emergency department and says, I am a patient who receives chemotherapy, those are not the patients who sit around and wait for several hours in the ED. We have to urgently triage them, immediately get vital signs, IV access, basic blood work, resuscitate them with IV fluids as needed. And then the international guidelines advocate that those patients must receive empiric antibacterial therapy within 60 minutes of presentation. So this is a quality measure in our ERs, and it helps reduce the mortality for those patients by ensuring that they receive adequate empiric antibiotic coverage within a reasonable time frame, determined to be 60 minutes. So when those patients come in, again, it's always important to remember, because you're immune suppressed, you may not present with the classic symptoms and complaints that a patient with normal immune system is going to have. So you have to do a thorough history and physical, check carefully for skin rashes. A lot of our patients have chemoports and may have some infections around their IV line sites or some rashes they may not be aware of. When patients get neutropenic, they can develop mucositis, so a careful oral exam to check for mucositis, respiratory symptoms, abdominal pain, diarrhea. Our patients are very predisposed to getting C. diff colitis because of their contact with healthcare facilities, checking for urinary changes and so on. We get a CBC with differential because we want to identify the degree of neutropenia. And often those patients are pancytopenic from our chemotherapy, so they're going to have a reduction in their other cell lines and may require some supportive transfusions as well. We check a CMP because remember, any renal or liver dysfunction can influence your treatment choice and can affect what type of antibiotic you need to use. Blood cultures must be drawn before you administer the antibiotics. So our ER colleagues will order peripheral and central blood cultures. If they have a central line, you have to get blood cultures from there as well. COVID, of course, is a big thing in today's world. You have to ask about their vaccination history. Remember that if someone just had a COVID vaccine, they might have a fever actually just from that. Or we do know that a lot of our patients with cancer are not mounting sufficient protection after receiving their COVID vaccines and can get breakthrough infections. So you ask for risk factors, exposure to ill family members or any travel, things like that. And then in terms of imaging, we really only image if there is a suspicion. So if someone is coming in with abdominal pain, you may want to image this to rule out colitis. If someone has respiratory symptoms, you image to look for pneumonia. We do not routinely just pan scan them without having an identifiable source. And then always remember, a fever could be the only sign in an immunocompromised patient. And in a lot of those patients, we are not able to actually identify the infectious source. So we're really only able to identify that source in maybe a quarter of our patients. And in a lot of our patients, they're going to have fevers that eventually will resolve once they recover their counts without us ever figuring out what the source was. Some people theorize that maybe this could be related to some GI translocation of bacteria that happens while patients are neutropenic and then sort of resolves on its own. Then shifting to treatment, what are the common organisms? So the big thing we always worry about in immune suppressed patients is gram-negative bacilli, especially Pseudomonas. And that's why our antibiotics are always going to have anti-pseudomonal coverage. Gram-positive cocci are also common. So Staph epidermidis, because this is basically part of your skin flora. Staph aureus and streptococci are always common organisms. Fungi is more for persistent and recurrent fevers, but not really for initial infections. Those are less common organisms that you think more if someone has persistent fever despite appropriate antibiotic coverage. And then I've pulled this table from up to date where you can see it's just mainly to illustrate that really the range of pathogens that you can get it can pretty much be anything. So those patients can really get any of the gram-negatives, positives, fungi, viruses. So you need to have all of this in the back of your mind if patients are not responding to our appropriate empiric antibiotic coverage. So when you choose your antibiotic, you want to make sure that you have anti-pseudomonal coverage. So what we tend to use here in the US where I practice is either Zosyn or cefepime. A lot of institutions have a preference to cefepime, mainly because it causes less thrombocytopenia than Zosyn. In a lot of parts of the world, I used to practice in Egypt before, so maybe fluoroquinolone coverage for an anti-pseudomonal coverage, depending on what you have available with the resources you're working with. There are some specific situations. If the patient is presenting really sick and septic shock, then you may actually want to add a second gram-negative coverage. So adding on something else like an aminoglycoside and adding an agent with MRSA activity like vancomycin. If you have obvious skin or soft tissue infection, if the patient is presenting, for example, with mucositis, you may want to cover MRSA then. So adding something like vancomycin. Here in the US, VRE is a big issue because of how much and how often we use antibiotics. So if a patient has a history of vancomycin-resistant enterococci, you may need to cover with linezolid or daptomycin. And then if someone is presenting with a high clinical suspicion for C. diff, is having a lot of watery diarrhea, you maybe had a history of C. diff before, then you want to add empiric coverage until you test for it. So what we use here is oral vancomycin. In a lot of parts of the world, we can use oral flagyl instead. That might be more available, either oral or IV flagyl. And this, I pulled this from MedEasy, which is a USMLE review resource, and it's just mainly to illustrate the different antibiotics and the different coverage, because I realize in different parts of the world, we use different agents. So it's just important to pick an agent that has some pseudomonal coverage, and then the MRSA coverage is added in select cases if you're worried, like I said, about mucositis or if the patient is presenting in septic shock. So this is just for your review. So back to our patient, that was the lady who has metastatic breast cancer who showed up a little hypotensive in the ER and was complaining of abdominal pain. So you resuscitate her, she got admitted, she responded well to IV fluids, she received empiric cefepime. Because of the abdominal pain she kept complaining about, we got a CT abdomen and this revealed evidence of colitis. So she kept receiving initially cefepime, but after she clinically improved and her ANC recovered, we ultimately narrowed down her antibiotics and discharged her on an oral course of ciprofloxacin to complete her treatment. Now, in a different scenario, let's say that it's the same patient. Let's say she responds well to IV fluids and receives empiric IV cefepime. And after 72 hours, all her workup is negative. So you scanned her, you didn't see any evidence of colitis. Her abdominal pain resolved on its own. Her fevers resolved, her counts recovered. So her ANC went up to 1600 and then 2000. So she's no longer neutropenic, she's no longer febrile, and you don't have a source of infection. And like I said, we see this often because in a lot of patients, we're not able to isolate the source of infection. So for this patient, you can actually stop antibiotics on hospital discharge because you don't have a source and her counts have recovered. So it's safe to just discharge her home without continuing any antibiotics. Now, in the third scenario, despite giving her IV fluids, she continues to clinically decline. She has persistent hypotension. You end up having to admit her to the ICU and put her on vasopressors. You broaden her antibiotics, right? Because we said we add vancomycin, we add MRSA coverage when patients are in septic shock. So she's on vancomycin and cefepime. However, 3 days later, she's still in the ICU, she's still sick, she has persistent fever. Your initial workup didn't really reveal a source of infection. So then what do you do next? So this is a patient who's having recurrent fevers and no clinical improvement, despite you employing all the routine empiric stuff that we usually do. So basically, we do see this scenario as well. And sometimes in those patients, what happens is that they have more of an atypical organism that is not covered by what you started empirically. So we start thinking about things like viral infections, fungal infections. You have to re-examine, reculture, re-image. Sometimes we do end up getting like CT chest, abdomen, pelvis in those patients to try to look for an occult source of infection. Maybe they have a retroperitoneal abscess. Maybe they have some sort of candidal infection because they have their chemoports. Maybe those can get colonized by organisms like Candida, for example. You want to review your antibiotic coverage. You want to make sure she's adequately being dosed, that the antibiotic levels like the vancomycin is reaching its appropriate trough, and so on. So those are all things that you think of when the fevers persist. If you are in a setting where you're able to get infectious disease colleagues on board to help and assist in management of those patients, then studies have shown that this can also help decrease mortality, just getting that extra expertise on board. And then just a word on cancer-related fevers, because I always hear that term a lot where people, when people consult me, for a patient who has neutropenic fever, they're like, what if those are just cancer-related fevers? So we do know that cancer in itself can cause fevers. We often see this on initial diagnosis, like a patient with lymphoma who's been developing some fevers on initial diagnosis before we find out that they have cancer. You just have to be careful with this, because if a person is hospitalized, is in septic shock, is neutropenic, I would always err on the side of, well, this person must have an infection until proven otherwise. While you can have a cancer-related fever, those are usually a little bit more low grade, and patients are not going to be hypotensive and ill-appearing along with it. So it's a diagnosis of exclusion. So do your due diligence in doing an appropriate workup before assuming that someone has cancer-related fevers. So we talked, the first part of the talk was more to discuss what neutropenic fever is, how do you do the workup, and how do you manage it. And then a neutropenic fever talk is not complete without delving into granulocyte colony stimulating factors, what we refer to as G-CSF. Those have a role in neutropenic fever management and in primary and secondary prophylaxis of neutropenic fevers. So just to serve as a little bit of a background, G-CSF, they're basically subcutaneous injections that we give to help your bone marrow, to stimulate your bone marrow, produce more granulocytes, produce more cells to fight the infection. So the question has come up of, well, do we use them when you have neutropenic fever? Does it help your bone marrow produce more white blood cells so you can recover quicker? And we've done a lot of studies on this, and the studies, it's been a little bit controversial in terms of the methodology of those studies, but most of the studies have shown that when you give patients with neutropenic fever G-CSF, the benefit is not so clear. They may reduce the length of stay in the hospital by a day or two, but they don't really impact survival. And so the IDSA here recommends against their routine use because of their unclear benefit and because they're also expensive. You're using an expensive modality of therapy without a proven benefit. Our ASCO Society, the American Society for Clinical Oncology, also recommends against their routine use, but sort of gave us a little bit of leeway to consider in certain patients. So we do use them in patients who we risk stratify as being very sick. So someone who is expected to have really prolonged or profound neutropenias, older patients with pneumonia, with sepsis, with invasive fungal infections, things like this. So what happens, honestly, in most of our practices here in the US is we do end up using a lot of G-CSF in neutropenic fever with the hope that it's going to reduce the length of stay, even though we don't really have a clear benefit from studies that this will have an impact on mortality. How much and for how long? One common formulation that we use here is filgrastim. And there are a lot of biosimilars now that are produced that it's basically the same agent, but it's the biosimilar formulation. So it's a cheaper formulation that is mass produced. Depends on what you use at your institution. We use here 5 micrograms per kg per day is the dose that you use, and you end up rounding it up to the nearest vial. So it comes in a vial of 300 and 480. And you use it according to the patient's weight. So if your patient weighs less than 60 kilos, you're probably going to use the 300 dose. If your patient is a little heavier than that, you will probably use the 480. There is no clear-cut guideline on how to use it, but what most of us really do is we continue it daily until the ANC is more than 1,000 for 2 days, and then we stop. And again, this doesn't really have proven mortality benefits, but we use it with the hope that it can decrease the length of stay for the patient and helps them achieve a more smooth recovery. The big thing for neutropenic fever is, well, how do you prevent future events? So, once the patient makes a full recovery and is discharged and comes to your clinic a week later, what steps do you take at this point to make sure that neutropenic fever does not happen again and that they don't end up hospitalized again for it? So in this specific scenario, it's the patient with the metastatic breast cancer who comes in to your clinic to discuss, well, what am I going to do about my chemotherapy and what is the plan moving forward? So a few things that we think about in clinic as oncologists. First question is, do I need to adjust the chemotherapy regimen for the patient? And this depends. This depends on several factors. So if your patient is undergoing chemotherapy for a palliative measure, so patient has metastatic disease and the chemotherapy regimen is simply to prolong life and to try to control the disease, but is not curative in nature, then you can reduce the dose of the chemotherapy. You can defer a cycle because you're not aiming for cure. So you have a little bit of flexibility in doing this. If the chemotherapy is being utilized for a curative intent, for example, a young patient who has lymphoma that you're trying to cure, then you don't want to cut down on the doses because then you may not be able to achieve a cure in the patient. In that case, you may need to do something else. So in that case, maybe you want to utilize G-CSF instead. And we'll talk a little bit as well about whether prophylactic antibiotics have a role or not. So in terms of adjusting chemotherapy regimens, this is what I just covered. Are you doing it palliative in nature or curative in intent? And that determines what you do with your chemotherapy in terms of delaying, deferring cycles, or adjusting it. In terms of using G-CSF, this specific situation is known as G-CSF as secondary prophylaxis. So the febrile neutropenia happened, and now you want to prevent it from happening again, because we know that if you develop febrile neutropenia, half of those patients will go on to develop another episode if you don't do something about it. And we know that if you give those patients colony-stimulating factors as secondary prophylaxis, then you reduce this risk by approximately 1/2. So this is something you may want to do, is add on G-CSF to your patient's chemotherapy cycles to prevent this from happening. What about prophylactic antibiotics? Patients, will often come to clinic and ask me, well, since I got this, should I just routinely be on prophylactic antibiotics? And so far, what we do know is that there is no role for routine prophylactic antibiotic suppression, because you're simply, you're just adding those antibiotics that can have side effects on their own without a known routine value. So what we end up doing is either if I can adjust something in my chemotherapy cycle, I do so. If not, I look at adding G-CSF to those patients to prevent febrile neutropenia from occurring again. And antibiotics are just limited on using them as treatment if febrile neutropenia does recur. And then what about primary prophylaxis? So as we know, the best thing you can always do is to prevent something from occurring to begin with. So the most ideal situation would be to prevent febrile neutropenia from occurring to begin with. So we do know that there are certain chemotherapeutic regimens that can cause an incidence of 20% or higher of neutropenic fever. There are certain dose-intense and dose-dense chemotherapy strategies. So certain regimens like the ones we use for breast cancer or the ones we use for bladder cancer. So all our oncology societies, ASMO, ESMO, and NCCN, all of them recommend that we use G-CSF as primary prophylaxis when the anticipated incidence of neutropenic fever is 20% or higher. And in those patients, you initiate the G-CSF at the get-go during the first cycle of chemotherapy. And then more recently, because of COVID-19 and the increased recognition that our patients with cancer tend to do poorly and have higher mortality rates when they are exposed to COVID-19, and we want to prevent the risk of febrile neutropenia to those patients as much as possible, our societies have actually lowered the threshold so we can use G-CSF along with chemotherapy regimens that are more intermediate risk, meaning that they carry a risk of 10 to 20% of causing febrile neutropenia. Why is this important? It's important because G-CSF, those factors are expensive. So to get them approved through the patient's insurance is not always easy. So when the societies lower the threshold, it means that I can get those agents approved and get those agents available for my patients. And then the other question that comes up, well, how long do you use the G-CSF for? Now, we do know that you're at highest risk of getting febrile neutropenia during your first 2 cycles of chemotherapy. And so out of this came up the question, well, do we need to continue the factors throughout the entire treatment course, or should we just cover the patients during the first 2 cycles of chemotherapy when they are more at risk? So we actually studied this and we looked at this as well. So there was a randomized trial that looked at 167 women who were getting chemotherapy for breast cancer on a regimen that had an estimated 20% risk for febrile neutropenia. We stratified them into 2 groups. One group got G-CSF during the first 2 cycles only, and the other group got it throughout all the cycles. And this trial, we actually had to close prematurely because an interim analysis showed that patients had a higher rate of febrile neutropenia when they received G-CSF during the first 2 cycles only. It was an impressive difference, so 36% versus 10% of patients. And so this is why our current practice is that we use primary G-CSF prophylaxis during all the chemotherapy cycles. So it's every cycle that you also get the protective G-CSF along with it. G-CSF in itself does not cause a lot of side effects. The big thing that the patients may complain about is they may complain about some bone pains or some fatigue. And just giving them Claritin and Tylenol actually helps with all the bone aches that they get. So it's not that the worst thing probably about it is it's a subcutaneous injection. And for some patients, they just don't like that route of administration and may not be comfortable giving it to themselves and may need to come and get it in clinic. Another thing that you also have to bear in mind is we want to avoid it with concomitant radiotherapy. So in a lot of the chemotherapy regimens, like the lung cancer regimens that involve radiotherapy along with chemotherapy. The reason being is we have 2 trials. There was the SWOG trial that looked at patients with small cell lung cancer who were getting concurrent chemoradiation and were getting supportive factors. And it noted that there was a higher incidence of thrombocytopenia and treatment-related death in the patients who got the supportive factors. And we really were not sure whether this was specific to the fact that they were getting thoracic radiation or whether the specific factor that was used here was the GM-CSF. We don't really know. But basically out of that trial, what happened is that most of us really will not give G-CSF when patients are getting concurrent radiation, the small cell lung cancer patients. And then there was another trial in head and neck patients, locally advanced oral and hypopharyngeal cancer patients who were getting concurrent radiation with factor support. And it was noted that they have reduced local regional tumor control. And really the mechanism of this is not known, But all in all, except in very, very select cases, most of us will not administer G-CSF in patients who are getting concomitant radiotherapy. So my take-home points from today is that neutropenic fever is a life-threatening oncological emergency. So early recognition is key and early appropriate management is key. I have 2 risk stratification scores at my disposal for illness severity, the MASC and the CISNE. And the main goal for those is to identify the select patient population that I can comfortably manage in the outpatient setting with close follow-up. For most of our patients, they're going to end up hospitalized, receiving IV anti-pseudomonal antibiotic coverage and a thorough infectious workup. If the fevers persist, you always want to think resistant and atypical organisms. So you start thinking outside the box about things like fungi, viruses, and so on. And then we talked a lot about colony stimulating factors, how they have a role in primary prophylaxis, so preventing the febrile neutropenia from occurring to begin with. Secondary prophylaxis, adding them on regimens after febrile neutropenia has occurred. And in select cases of neutropenic fever, when patients have poor prognostic risk factors in the hospital and you want to decrease their length of stay and ensure a quicker recovery. Thank you so much for listening. And I've put in my email address on here and my Twitter handle on here, but I made sure to leave some time so we can talk a little bit about any questions you may have. Thank you.
Perfect. Thank you so much, Dr. Abuali. Yes, so if there are any questions, you can put it in the chat and we can get them answered. I don't see any right now at the moment, but we can give like a couple seconds. If anyone has any questions, you can type them in. But if there are not, thank you again for this presentation. Always a pleasure to have you. And a lot of people will benefit from this presentation. So this will be posted on our website. And so it will be accessed for anyone who couldn't make it live. And we will be back the next time with another topic. Okay, if there are no further questions, then we can end this webinar.
Thank you so much.
Thank you, everyone.